So I think we will begin with our today's webinar that will be on COVID-19 crisis management. And we will try to make a comparative presentation of what is going on in Japan and the situation in France. And we will see that there are some common points, but also huge differences. Just as a way of introduction, I will give a few words to launch the discussion. The COVID-19 epidemics and its management by Japan have highlighted some elements that make the archipelago a kind of exception in the management of the crisis, on the consequences of the crisis itself. Japan was confronted with the same kind of interrogations concerning, for instance, the adaptation of the health system as other large Western countries. What is very interesting is that the measures adopted in Japan were less rapid, maybe, and less of course, also less authoritative than in countries like South Korea, Hong Kong, Taiwan, and of course, mainland China. This is the strategy chosen by Japan is extremely different from these countries. So we often speak of an Asian model in Europe, but there is no Asian model. There are different. There is a common result, which is a very low number of deaths in particular, but there are many different strategies depending on the different countries in Asia. And so, as I said, even without the same model as Taiwan and other successful countries in Asia, the infection rate in Japan today is very low. It's about 5 per 100,000 inhabitants, which is very low compared to our numbers. And however, Japan has also been confronted to a few problems that we do have also here, like insufficient number of intensive care unit. Actually, there is a large number of intensive care beds in Japan, but most of them are in the private sector, and it's extremely difficult to mobilize the private sector, especially as there are not that many cases to build a feeling of urgency. There are also, and this is very interesting, constitutional and political constraints that put a brake on the capability for the government to act on certain issues. There is a very high level of protection for individual rights and property rights in Japan, and you cannot adopt invasive decision-making by the authorities as easily as in other countries. So we will compare the situation between Japan and France, and we will have 1 hour to do that for this webinar. And I will first give the floor to Professor Suzuki. Professor Suzuki is we have two excellent speakers actually. Professor Yasuhiro Suzuki is a former Deputy Minister of Health until last year, 2020, and now is a consultant and professor on health affairs. And we have also Dr. Elisande Nexon, and she's Senior Research Fellow at the Fondation for Strategic Research. So as I said, we have 1 hour to do this for this webinar. So I will first give the floor to Professor Suzuki, followed by Dr. Nexon for approximately 15 minutes each. And then for the public, you have a Q&A button at the bottom of your screen, and you can use that to ask questions, and I will moderate these questions, and I will relay the questions to our two speakers. So we will have a short period of Q&A at the end of these, after the two presentations. Please do not hesitate to ask your questions rapidly if you want them to, if you want the questions to have a chance to be asked or relayed to the speakers. So now, without much more ado, I give the floor first to Professor Suzuki. Please, Professor, the floor is yours.
Merci, Valérie. I am Professor Suzuki. I used to be, as introduced, the Vice Minister for Health up until August last year. And I was also the Secretary General of the COVID-19 task force within the ministry. I would speak in the next 50 minutes about two things. First is to compare the rate of prevalence in France and in Japan. And secondly, I will try to explain, as Valérie mentioned, why do you think Japan's prevalence rate is much lower as compared to other European or North American countries? So I will share my files with you. Which one is it? I hope you could see. Oops, sorry. Oops.
We can see your file.
Okay. I will do it like this. If you look at the first slide, this is about the comparison about the daily new confirmed COVID-19 cases per 1 million population. If you look at France, the rate of prevalence in France is increasing in March. And I understand that France, the state of emergency call was issued a few days ago, as compared to Israel and United States and United Kingdom, where the rate of prevalence is going down. In terms of Japan and the world, we have much less prevalence of infection of COVID-19 as compared to the rest of the world. This is about the different types of comparison. First, you have the 0 to 20 years old on the left-hand side, in the middle 20 to 60 years old, on the right 60 or more or plus years old. And on the top range is the number of cases. And the bottom line is the number of fatalities. And the size of the area is the number of deaths or number of patients. And in the middle is the case fatality rate, which is the number of deaths divided by the number of the infections. And if you see in the bottom, the name of the country, such as Italy or Spain or Germany or France, I circled Germany and France in red. So what I would like to say is, first thing is about the 20 to 60 years old. We see many patients between 20 to 60 years old, especially in Germany, but we have almost no fatality amongst them. So the case fatality rate is almost 0. But if you look at the 60 plus age group, you see some larger dots in Germany for Germany and France, and the number of deaths for Germany and France. But if you compare the case fatality rate between Germany and France, the Germany is around 5%, but in France it's about 10%. I think it's about up until June last year. But we need to look at the reasons why the death rate amongst patients in Germany is lower than the patients in France. So this is the excess mortality due to COVID-19, which means to what extent people would die from COVID-19 as compared to 2019 or the past years. If you look at France, the excess mortality is almost 31%. But in Germany, it's almost 5%. So why the differences in terms of excess mortality between these two neighboring countries is very important, I think, for the future policy question. So if you look at the right-hand side, this is the other form of expressing the excess mortality. If you see the darker blue area, which is the all excess mortality, and the line with the lined circle is the mortality due to COVID-19. So it's largest in United States or Brazil or Mexico. In terms of the France, I would say the mortality for the last year, 2020, is almost 50,000. And you might wonder where Japan is. It's in the bottom on the right-hand side. It's not the circle to the upward, but it's a circle to the downward. As you might be aware, here in Japan, every year, the number of deaths would increase by 20,000 because of the aging population. But as for the year 2020, as compared to the year 2019, the number of deaths decreased by 15,000. So including these two factors, that would mean the death decreased by 35,000. Why? Perhaps, I presume, because the care of the older people with pneumonia increased because of COVID-19. People would wear masks, people would wash their hands, they would avoid the very congested situation. And this is, beside this factor, the number of deaths due to COVID-19 is almost 8,000. So that means we perhaps prevented the death, except for the COVID-19, in the scale of 43,000. I think this is a very major development. So I would try to explain why Japan's death rate or case fatality rate is much lower than that in Europe or North America. The Wall Street Journal called it a strange success, and people might call it factor X. The first, we have a different lifestyle as compared to people in Europe or North America. We do use the face mask, even in the usual years, in the spring or the winter time. And about the greeting style, we bow rather than kissing and hugging, and we take off shoes inside the home. Number two is about the history of BCG vaccination, because the prevalence in East Asia is much lower. And we do maintain the BCG vaccination in East Asia as compared to Europe or North America, where the BCG vaccination be eliminated. So that's why the people might wonder BCG vaccination might be working to prevent the COVID-19. But if you look at this graph from the Journal of American Medical Association, comparing two cohorts. The one cohort born in 1979 and between 79 and 81, who were vaccinated, BCG, and with the cohort born in 1983 to 1985, who were not vaccinated, and the difference in terms of prevalence between these two groups were not significant. So I would say BCG vaccination would not be very significant. And the next issue might be the racial difference in terms of the HLA type. Infection, if you look at the infection cases in New York City, the African American Hispanic are much more prone to infection as compared to Caucasians and Asians. And you might wish to explain by biomedical differences, but the people would wonder the differences between in terms of the educational or income differences between those different ethnic groups. And the fourth factor might be the cross immunity. Here in East Asia, corona flu is happening almost every year. So perhaps a few years ago, the very close to COVID-19, corona flu happened in East Asia. So people in East Asia might have some similar type of immunity to COVID-19. And the last one is the early response in long-term care facility for the elder people. I will explain it later. And this is the graph showing the biomedical differences amongst the different ethnic groups. If you compare the TMPRSS2, which is the protein expressed in the lung cell, and this is to facilitate the introduction of COVID-19 virus into the cell. And if you see the expression level amongst the Asian, African American, Hispanic, and Caucasian, only the African American population has the higher expression as compared to other ethnic groups. And this is the graph showing the different aging status. If you look at the x-axis, it is the rate of population aged 65 years old and above. So if you go to the right, the population is much older. And if you look at the y-axis, is the vertical axis, is the mortality among population. So almost all countries are in the line rising to the right. Only one exception is Japan, the red circle to the right. So Japan is the most aged population, but in terms of mortality, it's amongst in the middle, even to compare to other younger countries in Africa and in Asia. And this is about the comparison of stringency of policies in the x-axis, such as the school closure, the event suspension, or the restrictions on moving. So toward the right, 100 is the almost hard lockdown. Japan did some policy to prevent these type of infections without penalty. So Japan locates in the middle. And the y-axis is the population mortality amongst population. So if you compare Japan with France, one might say the hard lockdown might not be working to prevent death due to COVID-19. And this is the share of the death attributed to obesity, not related to COVID-19, but Japan has the much lower obesity ratio as compared to that in France. In terms of the male population, the BMI more than 30%, which is the definition of obesity. Japanese male has about 3 or 4% of obese population, but in France, it's almost 15.3%. It's about 5 times difference. And if you look at the other factors, such as the number of deaths per 1,000 inhabitants, Japan has the highest number, 13, as compared to France, which is about 5.9. So we Japan has perhaps more than double the deaths per population. And if you look at the Germany in the third bar from the right, it has around 8 deaths per 1,000 inhabitants. This might explain the differences between the Germany and France. And this is the graph showing the number of practicing doctors, physicians, per 1,000 population. So in terms of France, France has perhaps 20% more physicians working as compared to Japan. So this might not explain why Japan has the lower prevalence rates of COVID-19. And this is my last slide, which explains the COVID-19 vaccine administration ratio amongst 100 population. Israel covered more than 100% as of now, and the actual prevalence rate is decreasing. And so there's the United States or United Kingdom's prevalence rate, which administration rate is about 30 to 40%. But France has the much lower vaccination covering rates, and Japan has perhaps the lowest in most of the OECD countries. So I would hope that in the coming month, up until the end of this year, the most of the population in Japan will be covered by the COVID-19 vaccine, and the prevalence will be eliminated toward the end of this year. And I would hope that France does the same thing as well. Thank you.
Thank you. Thank you, Professor Suzuki. I will ask you to, thank you very much. And now I will give the floor to Elisande Nexon, for a presentation. Please, Elisande, the floor is yours.
Thank you, Valérie. Professor SUZUKI, ladies and gentlemen. First, I will perhaps present rapidly some key points of the French response, and then to highlight some challenges and to put the French situations in the context also of the European Union. The first part for France, for addressing this crisis, was the issue of addressing an external biological threat. And at this point in February last year, the main issue was the repatriation of French nationals that were in the area of the outbreak. So the actions at this point was to send medical threat to China to express solidarity, but also to organize repatriation operations. And it was organized by the Crisis and Support Center of the Ministry for Europe and Foreign Affairs, and it involved heavily the Ministry of Health and also armed forces. When the outbreak expanded worldwide, then authorities asked French nationals to come back with commercial airlines, and then they organized repatriation either through commercial airlines or specially chartered flights, but in coordination with other European countries. And the European level is highly important for France. At the same moment, French nationals living abroad were then asked to stay put and respect the lockdown rules of the host country. It highlights some political and logistical challenges, obviously, but it also showed that the works that had been done post-Ebola to develop and reinforce capacities in the field of transport of infectious patients was very beneficial. While there have been some shortcomings in terms of anticipation and response at later stages, at that point it showed that the administration, the public administrations, can be very reactive in these kind of situations. Then, when it arrived on the national territory, the issue was to respond to a public health crisis with an active circulation on the national territory. And I want to emphasize the highly centralized crisis management in France with a verticality. The place of decision, and it's very symbolic, is the Defense Council. And the authorities adopted a mainly political communication. There are different phases in terms of crisis management and decision making. With in the first week, the role of the Ministry of Health, which was put in charge of the response. And this had the effect to put the regional health agencies on the front line. So it was mainly considered as a public health crisis, with the issue that these agencies have not been designed to address crisis management, in fact. So it did not allow a coherence of actions across all services in France. It changed just before the first lockdown with the activation of the Interministerial Crisis Unit. It represented a shift because it associated the Ministry of Interior, and it was put under the authority of the Prime Minister. A specific commission that was put in place at the end of the first lockdown. It was not burdened with operational responsibilities and had to deal only with a strategic level to organize the exit of lockdown. And then after that, an interministerial crisis center and not a cell was put in place, was established with the aim of coordinating the state's response on the longer term. The difference was that there was a fusion of the crisis cells of the different ministries, of Ministry of Health and Ministry of Interiors. And it also associated the Directors General for the regional health services, as well as prefects, because in France, prefects are key actors, as they have the power to requisite assets. Some key features were the declaration of the state of emergency, and the Public Health Code provided a legal framework. It was adopted and then extended by law. This state of emergency allowed the Prime Minister to order by decree measures commensurate with the situation involved. And it includes measures such as restriction of freedoms of movement, to and from work, freedom of enterprise, and freedom of assembly, as well as the possibility to requisite goods and services necessary to end the health disaster, and temporary price control measures. But there was also a drastic reorganization of the healthcare system to be able to withstand the crisis. And for example, as you mentioned, there was the number of reanimation beds that we had to increase in the context of emergency. There were indeed plans, pre-existing plans, which we call ORSAN-B, ORSAN-BO, that aims at limiting the virus spreading and ensure that the care of suspected and confirmed cases. But when the virus began to circulate more widely, there was a shift from a logic of individual care to one of collective actions. There was also a shift in the medical community to health consultations by video, teleconsultations, but also postponements of non-emergency consultation and operation. It was not to the extent that we observe in some other European countries, but it had an impact on future healthcare. The health reserve was also solicited for reinforcement. So it put a strain on the public health systems and dramatically highlighted some pre-existing challenges. For example, the number of resuscitation beds that had to be increased in emergency conditions, some supply constraint and shortages of protection of protective equipment, diagnostics, and medical products of major therapeutic interest. It highlighted the phenomenon of interdependence that was also observed in many countries. So it led to the need to reassess national requirements in terms of supply chains and local industrial capacities. And for example, we rebuilt in France some industrial capacities for mass productions. Some general remark, perhaps, it applies to hospital, but also to the wider society, is that plans existed, we are land of planning, but they had to be revised. Besides, it did not mean that these plans had been adapted locally or were completely operational to deal with a crisis, with such a crisis. And other priorities took precedence over the years, for example, with terrorist threats and so on. And also, we have seen with some people that while the pandemic plans existed, perhaps the scenario was taken into account, but it was perhaps considered as theoretical by some people. So there was a difficulty to act in such a context of uncertainty and emergency pressure. I will also highlight that there were different challenges depending on the territory, with a difference between metropolitan France and the overseas territories. And for overseas territories, there were some challenges in terms of the number of intensive care beds available, with a difficulty in some areas to cope with an influx of patients. So they have to reinforce protective measures. but also some key problems of supply for medical supplies, obviously, but not only. And there is a key role of the armed forces to ensure provision of supplies in these areas, as well as to strengthen medical capacities. The armed forces were called to support the population as well as the public services. For example, to reinforce saturated hospital capacities, to organize the transportation of health professionals, as well as to evacuate infectious patients to less affected areas, to alleviate the burden of the hospital sector in some areas. Perhaps one observation about the civil society, there was a broad mobilization of the civil society with a key role of local elected officials with many local initiatives. For example, organizing specific COVID medical centers. Many companies and their employees participated by redirecting activities to produce key products, for example, masks or hydroalcoholic gels. And the population, perhaps this is a key point, complied much better than some expected. So this was quite, on this point, satisfactory to achieve such a mobilization among the population and the industrial sector. Perhaps some contextual elements that weighted on the response and highlighted some challenges. France is obviously a European Union member state, so we share terrestrial borders. And we are part of the Schengen area with free and unrestricted movement of people. So this was a challenge because countries had to reinstate controls and to close borders at some points. And there is a reform of the Schengen area that is announced following some lessons learned from the crisis. France is a land of transit to other countries, but also of tourism, with tourism being a key component of its economic sector. There are some public health considerations because the executive remained on some level traumatized by the highly controversies and posteriorly judgment of the 2009 H1N1 crisis management by authorities, especially regarding vaccinations, because they adopted precautionary principles. So this had a price, and people had a hard time understanding the costs because at the end it was not such a dramatic pandemic as it could have been. So this led to some taboos, for example, regarding mass vaccinations, the organization of mass vaccination, and this has had a significant impact of the response organizations. But this is progressive. This has evolved. This taboo has progressively dissolved in the context of current challenges. There is also a significant proportion of anti-vaxxers in the population in France, and this is a critical issue, as well as a significant proportion of people that are not adverse to vaccination, but need to be reassured, especially in the context of vaccines that have been developed very rapidly, and there is a critical need for explanation to explain that these vaccines do not come from. This is not a problem, a scientific problem. There are explanations about this rapid development. There are also cultural consideration because, contrary to Asian countries, wearing a mask to protect others was not at all a common practice. This has greatly evolved, and there is a great compliance now, but this was quite a shift in comportamental and behavioral dimension. Also, handshakes and hugs were a very important aspect of social behavior in France. So, in a few words, imposing a lockdown would have been nearly unthinkable just a few weeks before the first lockdown. Now, each lockdown, we are in the third one, I think, Valérie. It's not really a lockdown, but each period of lockdown or intense restrictions is different, as authorities have to adapt due to new scientific knowledge, but also to the need for the population to adhere to the restrictions. And as in other countries, there is a need to balance public health consideration with economic and social factors. There has been a massive support, financial support to enterprise. And the European Commission assessed that it was nearly a quarter of what was granted at the European level, this support. And in France, for example, compared with some other European Union countries, allowing children to go back to school was considered at one point a key element after the first lockdown, for many reasons, economical, but also psychological reasons, because virtual schools proved challenging for professionals, but also children and parents. And now just a few words about France as a European member state. It's worth remembering that health security and pandemic preparedness remain primarily a member state's competence, because it's not always obvious in the discussion or in the media. This crisis showed the need for enhanced cooperation at European level. As we had to tackle joint challenges. There were joint efforts to support research and the strengthening of health systems and provide mutual support to treat patients and address procurement issues, especially related to medical supplies. But there are main challenges pertaining to different administrative organizations and public health systems among member states, and there is a need for a better understanding. There are different levels of resources and of requirements, and also of expectation from the European Union. And for example, member states have never agreed on what the role of the European Union should be in terms of health policy. So the lesson learned include the difficulty to understand each health systems and their approach to crisis management. Then difficulty regarding the fast submission of comparable data at the European level between European member states. The difficulty to provide mutual assistance when multiple member states are affected. And there is the issue of people commuting in border regions, and the challenge to develop forecasts based on common modeling and to develop common indicators to tackle the crisis, as well as the translation of changing scientific evidence in policy and action around the language. So that's why there are projects to address a collapse in foresight, preparedness, and response by strengthening existing agencies, such as the European Medicine Agency or the European Center for Disease Control, but also to create a European Health Emergency Preparedness and Response Authority based on the example of the US BARDA. So, and I will probably stop here. Thank you, Valérie, Professor SUZUKI.
Thank you very much, Elisande. What is very interesting is that we see that there are huge differences between the situation in Japan and in France. And as Professor SUZUKI, the numbers you provided initially, including the comparison between Germany and France, are extremely interesting. And to try to understand, because this could happen again, I mean, that kind of pandemics, how to deal with it and why there are such huge differences, including between European countries. Elisande also demonstrated very well that, of course, the situation of Japan, an island country, is extremely different from France, which is a transit country, not only a European country, but all traffic going from north to south of Europe, from east to west, is crossing France. And the number of tourists is also very big, very important, plus border. A lot of workers in border regions now are working in Germany, or Germans in France. It's not so common, but in Switzerland it's the same. Belgium, a lot of traffic. So Europe in that sense really became a one entity with a lot of communications between the countries, much more than there is in East Asia. Even maybe Southeast Asia might be easier to compare, but even in Southeast Asia, communication is much lower. Sorry, transit between countries is much lower than what exists constitutionally, politically, diplomatically among European countries. So this is also, of course, a major factor. It's also a challenge in terms of crisis management, as we saw with what Elisande presented, but in Japan too. I mean, it's interesting to see, I mean, in Japan, the number of cases was much lower than in Europe. So maybe the urgency was there, of course, but there were not dozens of thousands of people dying or in necessity of emergency high intensive care units beds. So maybe it was easier to avoid difficult questions like how to find. Japan has one of the highest number of intensive care units beds in the world, but at the same time, when you live in Japan, which is my case now, you regularly can read the newspapers or listening to the news that we have to be careful in Japan because there is a risk of how do you say, not enough intensive care units beds, in spite of the fact that the number of people needing that kind of health care is not that high. And actually this is related to what I mentioned before, the discrepancies between what exists in reality, but what the government can do for constitutional political reasons. I mean, in Japan, the government is not allowed to enforce what was done in Europe, measures for lockdown, for instance. It's very recently that apparently governors can decide to put a fine on restaurants that refuse to close at 8 o'clock. But until now, it was just, telling their name or asking them politely, please do close at 8 o'clock. But if you don't want to do it, you don't do it. And nothing can be done. So there is no possibility legally in Japan to impose a strict lockdown. I don't know what would have happened to that soft crisis management system in Japan if Japan had been confronted to the kind of numbers we had in Europe. Maybe it would have been forced to adopt more restrictive measures in spite of the political difficulties. So I have one question from people listening to Professor Suzuki. This is a PhD candidate and is working on information communication, which is also an important part, as we see every day in Japan or in France, of that crisis. What were the main message of the Japanese government to the population regarding COVID-19, and what are there some things that could be improved or that are still considered to be challenging in terms of communication for the Japanese authorities regarding communication on COVID-19? So please, Professor Suzuki, if you want to tackle that one.
Thank you. I think up until August or September last year, the biggest issue for us was how to change the behavior of the people, especially the younger people, because even they get infected, they have almost no symptoms. So they don't care about the COVID-19, but they might infect their parents or grandparents. So the issue is how to stop the spreading the disease amongst the young people without the specific treatment or the specific vaccination. The only thing we could do is the risk communication with them, that they are the key to prevent the pandemic spreading across the population. So they have to be responsible for the whole community. I think this type of communication, I don't think we have done 100%, but because for the last 20 years, we have seen the 1 or 2 pandemics in every 4 to 5 years. So we will be seeing the repeating type of pandemics for the next decade or 2. So I think we have to improve the communication skill by the government or by the media to the people to ask them change the behavior, to avoid the congested situation, or to wear masks, or to wash hands.
Thank you very much. I don't know, Elisande, in terms of communication, would you like to add something for the comparative sake with what we did? I mean, we have, in Japan, there are a lot of press conference by the government on COVID-19. Of course, it is followed. There is a lot also when you go in the metro, for instance, this is not strictly the government, but when you travel by metro in Japan or in Tokyo, you have a lot of posters concerning about COVID-19, how to behave. The last one I saw this today, for instance, was very interesting. It was, of course, first it was only in Japanese, which means that for the time being in Japan, the communication towards foreigners in English, for instance, or even Chinese or Korean, in that specific poster disappeared in a way. I mean, before there were much more posters, security posters, for instance, on earthquake and so on in Chinese, Korean, English, but now it was only in Japanese. But the content is very important, I think. It was first you wear mask in the metro, which is absolutely, something everybody does. But then also you do not talk. You do not talk on the phone. And this is also very cultural. In Japan, no one speaks on the phone in the metro or public transportation. There is an announcement saying, please put your phone on manner mode, which is, polite mode, which is when you go into the metro, you shut off your phone. And you can, of course, read on it, send text, but no one speaks on the phone in the metro or public transportation, which is very different when you take the RER or train in France, where everyone is speaking. And used to until I left in December, taking off the mask to speak more easily. So of course, and speaking together, and in Japan also, when you are in the metro, culturally, you try to be in your own sphere and you don't talk with other people, even if you are, or very discreetly. So it means that there is very, very low level of talking in the metro or the train. So it's also a way to reduce the possibility to get infected. And the third thing on that poster was open the window at least 10 centimeters in the metro, which means that everyone, I mean, there is a stress of, how do you say, comment on dit aérer in English? I forgot how to say. I mean to open the windows to let the air flow. And there is a very strong stress on this in Japan too, including the metro where you can open the windows, which is not the case in RER now in France neither. I mean, it's very difficult to open the windows. So you cannot open the windows, basically. So all these things are very basic, but they are there. On posters everywhere, in the metro, in the train, in the stations. So it means that even if you are not a sticker to rules, you are constantly reminded on very simple way to behave and to help contain. So I don't know what in recent months, Elisande, there were new type of communication on this in France, because when I was still in Paris, I didn't see much of that kind of communication.
For the first part about the government communication, there have been regular meetings and presentation. At one point, it was each week by the Director General for Health from the Ministry of Health, and there was a very political communication and with regular interventions by the Prime Minister and the President. And regarding the communications, for example, in the subway, it's clearly announced. And when I was there, because now I'm in Germany, but people, there was a significant shift in behavior. People very rarely speaking on the phone. There were some people, but it was still significant to observe that I think that people mostly complied still, even if there are some exceptions. The problem is that there is a kind of wariness with the people who do not see the end of the crisis. But I think the main challenges we have in terms of communications is with dealing with messages from the that are very contradictory, even among, for example, scientists and the medical community, and as well as dealing with the rumors.
Okay, thank you very much. I have a question for Professor Suzuki. Japan has as we saw, has very specific factors and conditions. So it might be difficult to project Japan as a global model of how to deal with COVID-19. But still, there are things in Japan, I think, that could become, be used or projected as a kind of model. So could you, to other countries, how to try to prevent or deal with COVID-19. So maybe Japan put a lot of focus on one specific thing, which was 3 C's. 3C. Could you very rapidly explain what it is? Do you think this is a model that could be used elsewhere, not only in Japan, but elsewhere too?
Thank you. As Valérie mentioned, Japan is an island country, so it's relatively easy to control the cross-border movement of the people. So I think the lesson you could learn from Japan might be slightly different from this type of island country practice, which I said, as Valérie mentioned, 3 C's, which is I think it's the congested place and close contact, and I don't know, crowded something. So these type of conditions might be facilitate the transmission of infection, and you have to avoid. And the question is, why do you have this type of suggestion from the advisory board to the government? Because we searched and investigated not only the patients, but where these patients get infection. And these people get infections in crowded places with a close contact, not wearing masks, and speak loud with perhaps the alcohol. So this type of lesson will be congested into 3 C's, and not only to Japan, but these 3 C's message was promulgated by WHO, World Health Organization, to the rest of the world. So I think this is a very good example how this type of lesson could be extended from one country to another country. Thank you.
Thank you very much. And maybe I just, because this is very interesting for us to understand how also the crisis management, I mean, as I said before, Japan is a country used to crisis. I mean, for instance, natural disaster. I mean, there is typhoon, floodings every year. Earthquake. Recently, in 2 weeks, we had 3 rather, big earthquakes. So, so I mean, it happens. I mean, you live in a country where anything can happen suddenly, and in a very huge, very important natural disaster, tsunamis, of course. I mean, I just name it. And there is every year there is a white paper published on crisis management, focusing. The last one was published in 2020, so we don't have the new one, but it was focusing on natural disaster or nuclear consequences, of course, since Fukushima. Actually, there was no real reflection before what happened on pandemics. And we also know that pandemics is one of the new risks. And as Elisande said, we spoke a lot about pandemics, but a lot of people did not really get it or really believe in it. What we see today, we never imagined it could happen, even after SARS. So do you think there is a changing moment too in Japan, and there will be a special permanent task force to, to prepare for what to do with the next one, or, evolving? The white paper will take care of it too. Do you have any information on this crisis management system adapted to the new style of pandemics as we see today?
2 things. First, as compared to natural disaster and the crisis management folder, from my perspective, it's slightly different from the pandemics, because in terms of the natural disaster, we know the target and how it would affect the people. But in terms of this type of pandemic, we have to make the decision makings in the uncertainty about the disease's pathogenicity or the transmissibility. So this type of decision making is very difficult for any type of government. I think it's very important for all countries to learn from others, and these lessons will be handed over to the future generation. As I look back, we did the reflection about the H1N1 influenza pandemic in the year 2009. I was a member of that, the White Paper Commission. And we wrote down specifically at that time, we have to enlarge or strengthen the capacity for the PCR. And we have to enlarge or strengthen the capacity of the public health authorities, such as public health centers. But nothing happened during the last 10 years. So I strongly believe we have to learn from this epidemic and how we could minimize the casualties, and how we could find a way to balance between the infection control and the economic growth. And these 2 types of lessons are very important for the future generation and for the rest of the world, I think. Thank you.
Okay, so Professor Suzuki, I just check. So I have no more questions, and thank you very much, both of you, for your presentation. And that webinar will be put on the website of the Japan program of FRS, as well as on the YouTube channel of FRS in a few days. So much more people will be able to watch it. Usually this is the case. There are so many webinars now that people just keep it for a quieter time. So thank you very much again for your presentation and participation today, and to that dialogue between Japan and France on many issues that we try to maintain with the Japan program at FRS. Thank you very much, and goodbye to all. Bye-bye.
Au revoir.
Merci, au revoir.
Au revoir.